receive a new diagnosis of ovarian cancer, and about almost 13,000, I apologize, women will die from ovarian cancer in the year of 2025. And that is why this message on how we can outsmart ovarian cancer is so important for us today. So without further ado, I would like to introduce Dr. Rebecca Stone. She is an associate professor in the Johns Hopkins School of Medicine, Department of Gynecology and Obstetrics. Her area of clinical expertise is gynecological cancers, including cervical, uterine, vulvar, and ovarian cancer, as well as gestational trophoblastic disease. Dr. Stone is a highly skilled surgeon with expertise in laparoscopic and robotic surgery for gynecologic tumors. She also serves as the director of the Gynecologic Enhanced Recovery After Surgery Initiative, an innovative multidisciplinary program that improves recovery and healing time after major abdominal surgery, as well as minimizes healthcare costs for patients. Kudos. Dr. Stone received her undergraduate degree in biology from the University of Virginia. She earned her medical degree from the University of Virginia School of Medicine, where she subsequently completed her residency in obstetrics and gynecology. Dr. Stone performed a 4-year gynecologic oncology fellowship at the University of Texas MD Anderson Cancer Center. She also earned a master's degree in cancer biology from the University of Texas in 2010. Dr. Stone strongly believes in a multidisciplinary team approach to gynecologic cancer care. She seeks to provide women with the most advanced and personalized treatment plans while best preserving quality of life. She enjoys working with the community providers so that patients are comfortable by receiving care close to home. Oh, you are a doctor after our own heart. Welcome, 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 Dr. Stone. How are you today or this evening?
Hi, guys. How are you? Yes, I'm still in the OR. So in the spirit of that lovely introduction, I am, waiting for somebody who will need my help later this evening. And so you guys get me in the OR here.
In your full glory. Oh, we feel so special. Thank you so much for taking some time out of your schedule to have this conversation. You are a family here, and very much we would like to know one thing about you, a fun fact that you don't mind sharing with us here. How can we get to know Dr. Stone a little better?
Oh God, that's a good question. Well, I've been at Johns Hopkins for 11 years, guys, and I love working here, and I love our community. And I don't know, last time, did I tell you, I have a corgi. I don't have any children. I just have a corgi. I always tell people I think I had kids in my prior life. And so in this life, I just have a corgi. And so if you see me walking down the street, you'll see me walking a very well-fed cardigan corgi. So
oh, we love to hear it. We love to hear that. I love animals myself. I think they tend to be a little less messy than children,
I know. I always say, like, once I retire from medicine, I'm going to have like at least 8 dogs. I have to avoid, going to too many, dog shelters and that sort of thing. Because I would literally bring home every dog.
Oh,
so.
I can only imagine. So ovarian cancer. Let's get to ovarian cancer. I've often heard ovarian cancer be referred to as silent killer. Can you explain where it gets that name?
Yeah, that's a great question. So, people have called ovarian cancer a silent killer because it, folks have thought of it not having any symptoms, and before it's, widely spread in the abdominal cavity, meaning in the belly. And that's probably not entirely accurate. And I think, sometimes I call it that too, mostly in disdain. But I don't love that term because I think it basically tells people, like, don't even bother trying to think about whether you're having symptoms or not, right? It's sort of like is not empowering enough. It's like there's nothing you can do, so forget about it. the issue is it's not so much that there aren't symptoms, it's that the symptoms are very common. And they're common symptoms that we, particularly as women, normalize, throughout our life, right?
Yeah,
We have
yeah.
the time that we start having our period until we go through menopause, every month, we're used to having pelvic pain and bloating and some low grade nausea, maybe not feeling so hungry, feeling full. And those are the symptoms of ovarian cancer. And we've just like trained our brain, right, to ignore them so that we can continue with our lives of doing our jobs and taking care of kids and corgis and parents and all
And
the
it's not that bad. It can't be that important. I don't want to waste the doctor's time. I know I feel like that often. I feel like, oh, the symptom can't be that serious. Or I might experience a symptom of any sort and then it goes away for a couple of days. And so I think maybe it was all in my head. So I don't bring it
yeah.
up to the doctor. Oh,
Yeah, no, absolutely. And so I think that talking about it more that way, which is that, if you're having symptoms that they don't have to be unfamiliar symptoms, they may be familiar symptoms to you, but they're symptoms that are occurring, more often than not. Like I tell people, like if you on average, like if you kept a symptom diary and you are like every other day having these symptoms, especially if you're postmenopausal, right? The average age of diagnosis for ovarian cancer is 63.
okay.
So, most folks, once they go through menopause, and the average age of menopause is 52, these symptoms that we've experienced monthly, for decades of, bloating and belly pain and so on and so forth, they really should get ideally better after menopause. And so if you experience that and then all of a sudden you have these symptoms again, it's not like you're like gonna get your period again or something like that. It's just something's going on. And I think the other symptom that people often will have is like urinary symptoms, like urgency or frequency, which, I mean, all of us have had a urinary tract infection. And it's sort of getting to the point of, or, sort of the next point in all of this, which is that even doctors don't recognize these symptoms. It's not just that disease is hard for us like as patients to recognize, but also doctors, right? So like, because you go to a doctor, right, you're doing the right thing, and you're like, gosh, I feel like I have to pee all the time, and I'm
Right.
having this bloating, right? So they check, they're like, okay, let's check a urine culture. And maybe they're like, oh, you're not up to date on your colonoscopy. They send you to a GI doctor. And so the other thing that happens is that it's the recognition of this is delayed, right? So in that way, it's maybe silent as well, because women often see all these other doctors, or they see the same doctor multiple times before people are like, oh gosh, this is stage 3 ovarian cancer.
And by that time, it's kind of like a whirlwind. You just hit a rock and you're at
Yeah.
stage 3. That seems like to be a shape shifting. I mean, looking at the statistics that the ACS offered, it seemed like about half of those who were diagnosed will probably, succumb to the cancer, and that seems scary. So I hear that we have a way that potentially we might be able to avoid some ovarian cancer diagnosis. So let's dive into that a little bit. So what are some of the options, to prevent ovarian cancer? I don't think that is a
Yeah.
topic that we discuss often. You don't think about how you can prevent ovarian cancer.
Yeah, and I'm happy to bring up a slide, just because we're going to be talking about the reproductive organs, and I think that I don't know about you guys, but I mean, I spend my whole day every day thinking about them. But most people, if I say like ovary or fallopian tube or uterus, I think the vast majority of people sort of, give me a blank stare. Even other doctors, actually, my father's a physician; he's a vascular surgeon, and when I first started talking to him about wanting to go into OBGYN, he honestly could not tell you, really what a uterus did and whether it was responsible for hormone production or
Yeah.
not. So,
He said he is focused on vasculars. That's all he
yeah,
has to do.
So I'm gonna just I'll bring up a picture to show you guys,
Awesome.
and just so what makes we're all on the same page, because GYN is not something people think about every day. So this slide here is essentially talking about the fact that for many decades, when we thought about prevention of ovarian cancer, we really were thinking about women who are high risk, okay? And that means that, people who have, a family history of first or second degree relatives who had ovarian cancer, and or people who have genetic testing done, where they're found to have a hereditary mutation that really increases the susceptibility to being diagnosed with ovarian cancer, particularly at a younger age, right? So we said that the average age is 63, but for hereditary type ovarian cancer that affects high risk women due to hereditary gene mutations, those folks are diagnosed with ovarian cancer, at least 10 years earlier than the average person. And so, when we think about sort of people who are high risk versus, average risk, no risk, people who are high risk, make up about 20% of, the population of people who are diagnosed with ovarian cancer. So it seems like, oh, it's only 20%, it's not that much. But actually, ovarian cancer, when you think about all the different types of cancers, ovarian cancer is arguably probably the one that has the highest number of cases due to hereditary genes, right? So family history is really important for this disease and genetic testing. And so we, when this was discovered, right, that there was such a large proportion of ovarian cancer that is due to hereditary gene changes or mutations. This was discovered in like the mid 1990s. People then realized at the start of this century in 2000, like, oh gosh, like if we could identify these people with this high hereditary risk, we could offer them prevention by taking out their ovaries. And this is, what the female GYN organs look like. This is the womb or the uterus where a baby grows. And then you can see its appendages, so to speak, its fallopian tubes that come off here, and then the ovaries. And so, of this whole apparatus here, the only part that actually makes hormones is the ovaries. The womb and the fallopian tubes are what we say biologically inert. They, to our knowledge, don't make any hormones. And so the ovary makes hormones and it makes eggs. And when it releases an egg, this fallopian tube sort of acts like a, maybe like a baseball mitt or something like that, catches the egg, and the egg goes in the tube. And if it happens to be that a sperm comes up here, then the fallopian tubes, its only job is a rendezvous for, that's all it does. And so after you don't need a rendezvous anymore, or don't want a rendezvous anymore, then you can have your fallopian tubes removed, and it doesn't affect like how you feel or how you look. It just takes away that meetup spot.
Just like women that choose to have their tubes tied after pregnancy,
yes,
and they don't want to know. Okay.
Yeah, and we'll talk about that in a minute, because I think it's something too that there's a lot of confusion about. But anyways, so back in 2000, those were the first recommendations for surgical prevention of ovarian cancer. And the recommendation was that women between the age of 35 and 50, sort of depending upon what gene mutation they had and what their family history was, they were recommended to have their ovaries out. So for
but that just send them into like menopause at 35?
Yeah, exactly. Right. Because if you take the ovaries out, then that's the equivalent to menopause, when the ovaries stop making hormones that cause you to have periods. So like when you think about that, I think to your point, right, to go through menopause at such a young age is not great, right? It affects your quality of life, how you feel, causes brain fog, hot flushes, affects sexual function, causes a lot of vaginal dryness. And over the long term, if women are not started on hormone replacement therapy, it increases the risk of having osteoporosis as we get older, glaucoma, dementia, cardiac disease. So that, it's not such a great strategy, this idea of taking out the ovaries. And you can see that that actually has played out, over the last 25 years, and that these young women who have been recommended to have their ovaries out at such a young age, they don't want to do that anymore, right? And actually now, if you look at some of the most recent studies done on this, only 1 in 3 women actually, who are very high risk, but many of these women are women who have buried their moms, their daughter, their aunts, their sisters from this disease. They don't want to have risk reducing surgery.
That just seems like such a hard path to remove your hormones and have to take something, life already is like challenging. I can see how that adds, especially at 35, that's not something that I want to be thinking about at 35.
Well, and also for these high risk women, not only do they have a risk of ovarian cancer, they also have an increased risk of breast cancer. So the medical community has really held back on prescribing them hormone replacement. So, I mean, this to me is just heartbreaking because, the whole point is to decrease someone's risk, right, in a way that doesn't affect their survival as a human, right, later in life. Like if you do something and then you're trading off one thing for another, right? You're gaining maybe ovarian cancer prevention by having the ovaries out, but you're, losing some of your cardiac health because you have less estrogen during your 30s and 40s. That's not so great, right?
And I can see somebody wanting to take the risk, if it's not a guarantee that it would happen to me genetically. I can see how somebody can come to the conclusion like, I don't think I want to do this. But I also see how that puts a burden on the medical field of not being able to kind of help women survive ovarian cancer because they're already in that high risk category. So I see the conundrum that is trying to solve this problem.
Well, and I think, a lot of people, you could imagine like, okay, well, I'm not going to do surgical prevention and have my ovaries out. Well, then what could I do for screening, right? Is the most common question that I get in clinic. But the problem is actually there's no screening test for this type of cancer. And I can explain why that is. But I just want to make one other point on this slide, which is that, right now, the identification of high risk women is really sort of monolithically or solely predicated on family history. And we know that a lot of women, who are diagnosed with this, have no family history, right? Only 20% of it is related to genetic risk. The rest of it seems to occur in people who don't have any risk factors. And we also know that many people who have hereditary mutations associated with increased ovarian cancer risk don't have any family history. So like there's no family history to trigger a doctor recommending genetic testing. And so what happens, this is to me also the other heartbreaking part of this, is that you have people who are diagnosed with ovarian cancer and then get genetic testing after that. To find out that they, had this gene mutation all along. And that's like the ultimate failure of prevention, right? Then you have somebody who might have decided to do something preventive. So, So, to your first question, like, well, how do we solve this, right? So, no one wants to get their ovaries out. I don't blame them, right? Doctors are worried about prescribing hormone replacement therapy in many cases, even though I think there's a lot of, we don't have reliable family history to trigger genetic testing. Even when we do have a family history, we don't even necessarily want to get genetic testing done for a variety of reasons. And so this is like a whole big, ball of yarn. But there was a really important discovery that was made actually around the same time that risk reducing surgery started to happen in high risk women. So what started to happen is that people really started to study this disease. And they were, even though we were recommending that people get their ovaries out, when you look at the cells of ovarian cancer under a microscope, do sequencing on them, they don't look like they come from the ovary. They look like they came from the fallopian tube.
Wow.
And so, as it turns out, most of them do. Most cases of ovarian cancer come from this crazy organ right here, the fallopian tube. Remember, the rendezvous spot, not from the ovary. And that was such a game changer, right? Because
Very
as
much
I
so.
mentioned, tube doesn't make hormones, and so that means once you're done needing it for fertility, whatever that means, right? Either you never want kids, or you want to adopt, or you had your 9 kids, or your 1 kid, or whatever it means, then the fallopian tubes can be removed and not impact your hormone function, because you get to keep your ovaries. So
That in and of itself is an amazing concept, because kind of like we mentioned before, a lot of women are okay with the concept of tying their tubes, which essentially does the same idea of not allowing the egg to travel. And so if you're going to tie it, might as well just take it off.
yeah, and I had actually put because we've done a couple of these over the last week, just because it's GYN Cancer Awareness Month, as you mentioned. And that question comes up a lot. So I actually added this little, these little graphics here. And this is what we're talking about is, tying the tubes. First of all, also, I'm like a words person, like words matter. This term of tying the tubes is a term that originated in the late 1960s, when there was this era of forced and coerced sterilization. And so that term was actually invented by the eugenics movement to try to make women think that, oh, it's just, we can tie your tubes and then you can untie them as easily as untying your shoe or something. When in fact, the procedure is and should be considered permanent and irreversible. But you're right. I mean, it focuses on the rendezvous spot of the sperm and egg. And so when the tubes are tied, they're not actually tied. What happens is either the middle part of the tube is removed, so it's like interrupted. So an ovary, gets here, but it can't get to the uterus, and a sperm comes up here, but it can't get to the egg. Or sometimes it's not that little segment isn't removed, but there's a band that's put on it to cause that interruption, or a clip.
Kind of like pinching off a water hose.
Yes, exactly. Like, just basically it's preventing a sperm from coming up from the uterus and an egg, or coming over from the ovary, from meeting up in the tube. And so and so you can see by this picture, if we go back to this one, the cancers actually start in these little finger projections of the tube, which makes sense, right? Because that's the part of the tube that sits right next to the ovary. And that's why people thought this came from the ovary, because these little cancers actually form in these fingers of the tube, and they slough off, or sort of like dandruff, onto the ovary. And it's on the ovary that they grow into a mass, as opposed to the tube. A lot of times, when a mass forms, you just see it really in the ovary, and sometimes the tube can look actually quite normal, or the tube gets just sort of like obliterated by the mass. And so it sort of just like takes over this end of the tube and ovary, but it really looks to our eye that it, comes from the ovary, when in fact it comes from the tube. But so you can see that when you're tying the tubes, all you're doing is focusing on interrupting the tube. You're not actually taking out the tube. And that's
Right.
It doesn't reduce the risk of ovarian cancer very much. Maybe a little bit it does, because there are some ovarian cancers called clear cell and endometrioid ovarian cancers that actually are endometrium, like endometriosis from the uterus, that gets onto the grows into a mass. And so just blocking the tube can prevent that process of that endometrium or endometriosis getting to the ovary. So tying the tubes might decrease the risk of those types of cancers a little bit, but not the most common and deadly type called high-grade serous cancer.
Which comes from the fallopian tube.
Yeah, we think by far and large.
So side note, is there any talk of this being called fallopian tube cancer rather than ovarian cancer?
Gosh, I would love that. I
Just
think
seems more accurate.
I totally agree with you about that, honestly. And you know, I I really have spent a lot of time trying to create education materials for folks about this, and we have a website sort of devoted to all of this. All the stuff we're talking about today, and we're just about done with it. We should have it be live this month. That's our goal. And so when we do, I'll send it over to you guys, and you can send it out to the community so people.
We would love that. For anybody watching, I'll make sure I add it into our October newsletter that you guys will receive.
Yeah. We have some PSAs. I actually have a PSA that we worked with. And we have a filmmaker that works on our team. And I'm happy to show it to you guys later. I'd love your guys' input, maybe towards the end of this talk, but.
Sure, that sounds awesome. Thank you for letting us get the first insight, this first scoop.
I know.
So with this newfound option, right? I have the option to remove my fallopian tubes to reduce my risk because I'm deciding I'm done having children. How do I go about having that conversation with my doctor? Is it something that they would be aware of?
Yeah, so I think that that's a great question. And I would say when I started working on this a couple years ago, I was under the assumption that everybody knew about this. And when I talked about this in some circles of people where you would expect people to know, like the CDC or the American Cancer Society, or other groups where there are people who do a lot of cancer research, for instance. Actually, very few people had ever heard of this discovery, and often wouldn't believe me, and they would go fact check me, and they would be like, "Oh my gosh, you're right." I was like, "I know." So at any rate, I would say back several years ago, maybe not as many people knew. Maybe a few more people know now. But one of my major goals, and one of the goals of this website, and sort of all of the sort of education curriculum we're developing, not just for the public but for providers, so that when people do talk to their provider about it, whether it be a general surgeon because you're maybe going to see somebody for a hernia repair, or you're interested in a hysterectomy for a fibroid or something, or you're done having kids and you are thinking about having permanent contraception, that when you talk to your doctor, they will validate that this information for you. I think a lot of OBGYNs know about this because it's our wheelhouse. But beyond that, like family practice or, an internist or a general surgeon are less likely to know about it. And our goal is really to reach all those providers so that this information is universally known.
Yeah, because I feel like, a PCP might suggest going to a GYN for tube tying. So I feel like this should be an option as well if you bring that up. And so as a patient, are there any specific criteria that I have to be a good candidate, or something that would disqualify me from being a good candidate?
Yeah. So I put together this slide. It's a little bit busy, but I can explain it. I think the number one criteria you've already mentioned, which is just that you have to not need your fallopian tubes for fertility. And that doesn't mean you couldn't get pregnant, even with your own, eggs, if you had your fallopian tubes removed. But what it means is you would need in vitro fertilization, which is becoming more and more common. So I think that's the number one eligibility criteria. And then I think the next thing is really to know if you can, to the best of your ability, and I know there are some limitations with this, to know your family history. Because, folks who have a family history, like a family history of first or second degree relatives with ovarian cancer, should should really talk to their doctor. Honestly, regardless of whether you're interested in any of this, talk to your doctor about being referred to a genetic counselor to talk about genetic testing. Because if that genetic testing is positive for a hereditary mutation, then that means that you're a person who has this increased risk of developing ovarian cancer at a younger age. And we define that as somebody who has greater than 4% lifetime risk, meaning that the average risk, you can see at the bottom, is probably somewhere around 1.5%. So a greater than 4% risk means, you're 2 to 3-fold at least. When you think about BRCA, those people are so high risk because they have a 20 to 40% lifetime risk of developing ovarian cancer. So very, very high chance.
Mm.
And so this then sort of describes, like, if you are known to be high risk due to positive genetic testing, right? We used to tell you needed to get your ovaries out at 35, but now people are starting to think about maybe getting their tubes out right away and then waiting to get the ovaries out until closer to the natural age of menopause. And this decision really should be made in a shared decision-making conversation with ideally a GYN oncologist. And so if there's anybody on this call, who's interested in this, you don't have to see me. You could see one of my partners, of course, or whomever, but I think this is something that most, general GYNs are not really comfortable with yet, because there's a lot of nuance to this. And then, maybe you have a family history of ovarian cancer and you did have genetic testing and it was negative, or you don't want to have genetic testing, then you might consider having your fallopian tubes out, just getting them out, as soon as you're done, with your tubes. And we always say 10 years earlier than your youngest affected family member. And then but this is like these people, high risk and moderate risk, this is like only 1% of the population in the world, right? 99% of people only have a 1 to 2% risk of ovarian cancer, meaning a 1 in 100 or 2 in 100 chance. And for those folks, we say, you might consider having your fallopian tubes removed opportunistically before the age of 50. Like, what does that mean opportunistically? And we'll go back to this slide. That means, if you are going to the operating room, for some other reason, right?
Mm-hmm.
You're going to go anyways and have your tubes tied. Well, okay, well, maybe you think about the alternative of having them removed. It really doesn't change the procedure at all, or the risk, or the time needed, or the recovery time, or anything like that. So you would take the opportunity to choose fallopian tube removal for the dual benefit of pregnancy prevention and ovarian cancer prevention. I hate that we call it ovarian cancer, so confusing.
But I remember one time, at one point, doctors were a little trepidatious to do tubal ligations on women who were under, a certain age. And I have a question from the chat. So is there an age restriction? Like, what if I'm a 25-year-old female who's had 4 children and I know I don't want any more? Is this still something that I can consider?
Absolutely. I think that's actually, it's not uncommon, actually. And we know from the literature that women who decide to have a tubal ligation or fallopian tubes removed under the age of 30 are more likely to have regret, but that doesn't mean you will necessarily have regret. I would say regret is just as common over not being able to get access to this procedure, or having an unintended or unanticipated pregnancy and being in that situation. And so I think it's a balance, and I think it's just, making sure you find a doctor who you're comfortable having that conversation with, where you feel empowered, you feel supported, you feel heard. So absolutely. I think, for people who have Medicaid insurance, they may require you to be over the age of 18, I think, in order for the procedure to be covered by insurance. I can't remember exactly. I'd have to look to be sure, but that might be, one of the situations where there's a strict age threshold.
Okay. And then I have another question from the chat. They said, are there any states where this cannot be done?
Do you mean a salpingectomy for prevention?
Yes.
Fallopian tube removal for prevention, yeah. So I would say by states, I imagine you mean geographic states.
Yes.
Okay. So that's a very interesting question, actually. And honestly, if you had asked me this a couple of years ago, I would not have known how to answer this question. And honestly, the way that I came to know about this was by looking at some of our own internal data, right, at Johns Hopkins. Johns Hopkins is so interesting because it straddles Washington, D.C. and Maryland. So we kind of like have this health system that's in two different states. And so if you look at some of the old Hopkins data, from several years ago, you see some odd trends, like women were more likely to get like a tubal ligation in Maryland, for instance, than if they lived in DC, or maybe if they had certain types of insurance or whatnot. And so that got me looking at some of the health policies surrounding, permanent contraception across different states, including Maryland. And what's interesting about Maryland's Medicaid policy for sterilization is that it hasn't been updated in a long time, I think. There's a couple ways that that. One is they still have this procedure on there called Escher. I don't know if you guys have ever heard of this, but it would be when a doctor would put like this like spring coil up through the uterus.
Oh, in the fallopian tubes?
Yeah. And that basically has gone off the market many years ago, but it's still in the Maryland sterilization health policy. What our health policy doesn't have, even though it still has Escher, is it doesn't include coverage for the option of salpingectomy. And so you just see that tubal ligation is listed as being covered. And, so that is problematic because a lot of private payers, they follow what Medicaid covers a lot of times. And so if Medicaid or Medicare doesn't cover something, then a lot of times other insurance carriers won't cover it. And, actually, speaking of that, we do some work with the National Women's Law Center because we are working on a lot of the health policy structural barriers related to this as part of we call it our Outsmart Ovarian Cancer Collaborative, which is, I'll show you guys, it's really big right now. This is our collaborative. When you talk to the folks at the National Women's Law Center in DC, they will tell you exactly this. They're like, gosh, our hotline, our contraception hotline is full of these phone calls from patients basically saying that my insurance carrier won't cover, the procedure code for salpingectomy, or won't cover a fallopian tube removal and how to handle that.
And that's tough. That's a hard position to be in, both as a patient. Yes. Before I go into trying to figure out what the community can do to raise awareness and try to address this issue, I do have a question personally. So I do know, with fallopian tubes, there is a potential for an ectopic pregnancy, whether that's in the fallopian tubes or somewhere outside. When you remove the fallopian tube, do they seal off the hole that goes to the uterus? Okay.
Yeah. So to your point, we think, although, we're trying to get all of this epidemiologic data in the US because, women's health, there's not a whole lot of research. And so it makes rational sense that there would be a lower rate of ectopic pregnancy for people who have their tubes removed. So it's potentially another benefit. But we really need to get US population level data to prove that. But it makes sense to us.
Yes, I was curious, and then I thought about, I was like, wait, they probably sew it up so that there's nothing that can go back.
Yeah. Well,
just for a woman who's under menopause age, scary things that get pregnant on your liver or something.
Yeah, I mean, it can happen. And I mean, I think along those lines, right, is also how effective the two procedures are. If you are wanting the most effective form of permanent, contraception, then it's fallopian tube removal, right? Much more effective, we think, although, I can't tell you the exact number. I will get it though. how effective it is compared to a tubal ligation. So, because there is still a failure rate with tubal ligation. It might be even in like 1 in 100.
I have another question from the chat. I might need some clarification, but maybe you understand. It says, even if there is remote FH, will this improve chances of procedure being covered?
Remote, like family history, maybe, is that what they mean? Like if you have
Maybe, yeah,
like
maybe,
maybe
sure.
like your great grandmother or something, like, so not like a first or second degree relative, but like
I'm gonna
third or
assume
fourth
so. Like, would
degree.
we be able to
Yeah.
justify, I guess, like, with a prior authorization, is there any way that we could probably kind of tap dance around
Yeah.
getting the code approved?
Yes, I would tell you yes. And I think the reason I say that, and that's again why it's such a nuanced interview between like a GYN oncologist and the patient, because in a lot of communities, and I mean, right, hysterectomy and tubal ligation and fallopian tube removal and all these things, are such common procedures for women. And so it may be that the only family history you have is a great grandmother, because your grandmother and your mother had a full, what people call full hysterectomy. So the uterus and the tubes and ovaries removed, right? For some reason, in their 50s or something. And so, they basically got prevention via, needing to have surgery for something else. And so that's something that can come up. And so it may be that it's not that your family history is negative for your mom and your grandma. It's just that we don't have that information. It's unknown because their opportunity, thank God, to get this cancer was they took that opportunity. Does that make sense?
Yes, it does. And it seems because technically that your mother or your aunt or your grandmother, they may have never technically had a history of ovarian cancer because it was prevented.
Right, exactly. And that's very common.
Which makes complete sense. I
Yeah.
have another question in the chat. It says, it seems the conversation is around diagnosing women under age of 50. Is this also an option for women over 50?
Yeah, I think that's a great question. And so I would say yes right now. The reason why in this slide I said, for average risk people, the 99% of the population might think about moved opportunistically, like at the time of another procedure in lieu of tubal ligation, at hysterectomy, et cetera, before 50, is that there's some early data out of Denmark indicating that the effectiveness of this as a prevention strategy may be not as good after the age of 50. And we don't know why that is, but we think that one of the reasons may be that, as we get older, our chances of having minute precancers or even very, 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 very early cancers in the ends of the fallopian tube starts to go up after 50. And so, most of the time, right, we think that when a tiny cancer forms in the tube, it's 7 years from when it forms to when people get diagnosed. And so, so when you think about that time lag, if you're getting your tubes out when that cancer or precancer has already started forming, then the effectiveness of this as a strategy may go down. And I do want to also point out, I don't know if it's in this slide deck, but no, I don't think. But it's not 100% effective. Okay, it's very effective. So when we think about ovarian cancer, the most common type, like if you Google ovarian cancer, you'll see high-grade serous cancer. That's the cancer that's goes all around, all on the surface of everything. And fallopian tube removal decreases the risk of that by 80%. Okay. So it's not 100%. There are several reasons. Part of it may be an age factor until they're older. But also remember, there are some types of ovarian cancer that probably do actually come from the ovaries. And they're like germ cell tumors or cancers called granulosa cell tumors. Those are actual ovarian cancers. I mean, they account for less than 20% of what we call ovarian cancer, but they do actually come from there. And so you can still get ovarian cancer even after having your fallopian tubes removed. And so the only way to completely eliminate the risk is to have the tubes and the ovaries removed, right? And so there may be, speaking of age, there may then be an age at which, you know, you want to have ovarian cancer prevention surgery, right? Like say you're, I don't know, you're 60 and you need to have a hernia repaired. And you're like, oh, I want to have ovarian cancer prevention surgery. It may be, as we learn more about this, that we say, actually, you know, you should just get your tubes and ovaries removed because you're now, you know, almost 10 years remote from menopause. We actually know, which we don't even know, what types of hormones the ovaries make, you know, at each decade of life. It's something we desperately need information about. But there may be a point at which we say, just go ahead and have tubes and ovaries removed.
Yeah, that makes a lot of sense because at this point, you don't need any of the potential hormones that the ovary might make. And then it also takes out the risk of any of the cancers that originate in the ovaries as well. I think that
Yeah.
that's a great kind of compromise, if you will.
Yeah.
So in general, what can community members, organizations, individuals, what can we do to raise awareness about this new prevention method if within our communities? And then also, is there a level in which there's work that we can do to help this like affect insurance and policy changes?
Oh yeah, that's a great. So first of all, I mean, just this is fabulous, and I'm so grateful, you know, to have the opportunity to interact with you guys over this. And you know, we just say, you know, people always say, well, like, what do you want us to do? And so what I would say is just to be an amplifying voice, right? Because for this life-saving message, and so that, you know, if we always say that women and really people in general, right, our superpower is passing on information. We're actually really good at it, and especially women. And so it's sort of this idea of like, okay, you tell 10 people and they'll tell 10 people and they tell 10 people. And before you know it, right, we sort of have this grassroots, knowledge mobilization, so to speak. I think that, you know, we really need to work to make sure that other doctors know about it so that they can be a source of validation for the public as the public, you know, passes along this message. And I think that, you know, the other thing is, I always tell people, it's not that we're telling people that they should go get their tubes out. What we're telling people is we want you, the public, to know about an important scientific discovery, an important discovery in medicine that may be important to you, or it may not be, right? And it just depends upon where you are at in your life and what's going on in your life. And you know how it is. Sometimes things are highly relevant to us and sometimes they're not relevant at all.
Yeah,
And
it's an option.
yeah, it's just knowing
You're
about the option. Like
option.
you're thinking about getting your tubes tied, you would say, or like say your best friend says to you, hey, I'm going to get my tubes tied next week. You might say, hey, have you heard that most ovarian cancer comes from the tube and maybe you should have your tubes removed, right? And so being that sort of amplifying voice, I would say, is the single most important thing any of us could do.
That is great advice. And this is recorded and we will share it with everybody registered. So please forward it, pass the message, visit our YouTube page because you'll be able to replay this message as many times as you need to. So I do have one question, more so kind of specific to you and your practice. Have you had any patients that have successfully gone through this procedure? And what was the outcome and, you know, their feedback?
Yeah, I mean, this is awesome. So so two things, and then I'll show you guys our little PSA because you guys will be the first people to see it. But it's all along these lines. But so two things. So one thing is the other thing I would say is, again, we're not telling people to do anything. We just want you to know about this. And you know, surgery and surgical prevention is not an option or not something that everybody is in love with, and that's okay, right? I mean, I'm a surgeon and I don't want surgery, although I am going to get my own tubes out because I think it's you know, very impactful things to do. But you know, birth control pills, people who take birth control pills for a variety of reasons, right? Nowadays, acne or you know, deep bleeding or you know, birth control. Also decrease the risk of ovarian cancer, probably because they decrease the amount of ovulation damage that occurs to the tube, the fallopian tube over time, right? Because they suppress ovulation. If you take birth control pills for at least 5 years, that's been shown to decrease the risk of ovarian cancer by 40 to 50%. So, I mean, that's pretty good risk reduction. It's just, you have to know that you've got to take them for that 5-year period of time. And then the second thing is that, yes, so I do, as you can imagine, a whole part of my practice now is devoted to prevention. And I see anyone who wants to come talk to me about prevention is welcome. I actually see many Hopkins doctors, nurses, staff who want to come and talk about this, or their wives or their, sisters or whatever. And I'm happy to see anybody. What some of the most amazing things that we've done at Hopkins is we started a pilot of fallopian tube removal at the time of urologic surgery. And we've also started a trial of fallopian tube removal then in the general surgical community at large. And here at Hopkins, we actually had one patient who had their tubes removed at like 52 when she was having surgery for bladder cancer. And that's a pretty young age to have bladder cancer, actually. And so she had her tubes removed, and she had a high risk precancer in one of the tubes, the type that has at least a 30% chance of becoming ovarian cancer over 10 years. And so, talking to her, and even, the urologic surgeons, we were all so touched by this case, because we're like, gosh, here we were in the position as doctors to save her life, right? From the cancer we knew about, her bladder cancer, and from a cancer that none of us, including her, would ever even know she was going to get for another several years.
4 years. Wow.
So that was like really, for me, what it's all about.
Validating, I bet.
Yeah.
Oh, well, I have one question, but I want to get to the PSA, and then I'll ask the question at the end.
Okay, sounds good. All right, I'm going to show you guys this, and feel free to, give me any feedback or comments on this. This actually, the script for this PSA came from our community outreach and engagement work. And our community members actually wrote the script for it. So it's so cool.
Oh, that's amazing to hear.
Yeah. So, all right, I have to share my sound, which I'm never very good at. Oh, wait, hang on. I don't think I shared my sound. Okay, and then I'm going to enlarge this, and then I'm going to rewind it. Okay, then you guys should be able to hear it.
Mark. Take one, soft sticks, Mark.
That's
interview number 5. Take one, soft sticks, Mark. Soft sticks, Mark. Mark. Do Mark.
ready to save the women you love. Your mother, your aunt, your sister can have an 80% lower chance of dying from ovarian cancer.
Every 40 minutes, someone is diagnosed with ovarian cancer in the US.
The biggest risk factor is not your ovaries, but your fallopian tubes.
80%.
80%.
80%. 80% of ovarian cancer
Actually originates in the fallopian tubes. In the fallopian tubes. This is one of the greatest blind spots in the history of women's health, responsible for the loss of thousands of women every year.
Fallopian tube cancer has no screening,
No screening.
no screening.
No screening and is undetectable until it spreads.
That is why it is so hard to cure. Since this is the case, and since we now know that
Most ovarian cancers are actually
fallopian tube cancers, fallopian tube removal
Fallopian tube removal.
Fallopian tube removal is a cancer prevention option that everyone should know about. Fallopian tube removal, also called fallopian tube removal. Fallopian tube removal, often called salpingectomy.
Salpingectomy.
Is a quick,
simple procedure that can be done instead of a tubal ligation.
or in conjunction with other abdominal surgery. It's an option for women who don't need their fallopian tubes for fertility. You can be an amplifying voice for this life-saving message. Great? Okay.
Yeah.
Great.
All right, let's cut. Very good.
Yay!
That was awesome. I felt like I was watching TV already. So go ahead and publish it. It was awesome. And I really like the message. It was more about awareness and giving us a piece of education. And like you said, not telling us to do anything or make any specific decision. I really, really enjoyed that. If you wouldn't mind, if you would share that with me, I'd also like to add it if you're open to that being shared.
Yes, absolutely. Yes. As soon as we're going to put it on the website, and then I can send you each separately. So people can view it on the website, but I'll send it to you as just its own PSA.
Perfect. That is awesome. And so the last question that I have for the night before I let you go is actually not about ovarian cancer. I guess from your bio, somebody was inspired and they wanted to know a little bit more about your enhanced recovery after surgery program.
Oh my gosh, I love that. Great. Thank you guys. So, and I'm happy to do something related to that. If you guys want to do another one of these COEs for that. So, the idea is that when people have surgery, right, it causes stress to the human body. And a lot of that stress that's inflicted is what makes recovery hard and what makes recovery long and can increase complications, right, after surgery. And so we actually know now, because of science and research, how to decrease surgical stress. And so this is a program that's built around protocols for people having different surgeries, right? Like one for a C-section, one for pancreatic surgery, one for hysterectomy. All that data goes into a protocol for, like 35 things that your doctor can do to reduce the stress of that surgery on your body so that you can recover faster and better.
Oh, that is awesome. I think that we will reach out to you and see if we can loop that into a conversation, because like a whole hour we can spend on that in itself. But Dr. Stone, thank you so very much, not only for the information that you've given us tonight, but for taking time out of your schedule, because we know you are busy. So we appreciate
my pleasure
so much for helping us spread this word. And we look forward to being an amplifying voice for you.
Thank you guys so much. Seriously. I couldn't ask for, anything more. And so I'm really grateful to spend this time with you.
Thank you so much. Everybody, once you log off, you're going to be prompted to a survey. If you can take the survey for us, we would greatly appreciate it. Have a wonderful night.
Thank you guys.